Now we will start with our next session. With that, I would like to invite our respected chairpersons, Dr. Brett, Dr. Chaitanya, and Dr. Stephen. I would like them to proceed further.
Good morning, everyone. We'll start the session, which is the wild card, diverse topics in hand surgery. I would like to call the first speaker, Dr. Sudhajit Sen, who will be speaking on ultrasound integration, enhancing precision in hand surgery.
Good morning. Shall I start now, or I'll let them sit down? Maybe a couple of minutes.
We have 1 minute to go.
We can start, I think. Thank you.
Good morning, and thank you very much for this opportunity. My name is Sudhajit. I'm one of the consultant hand surgeons from Regmo Hospital in Venice, and this is my topic today, ultrasound. Disclaimer, I consult for a sovereign medical group who produce the devices called Spireka devices, and I'm one of their key opinion leaders. And some acknowledgement towards Dr. Subhasis Basu, who is an MSK radiologist from Wrightington Hospital. So, why ultrasound? Ultrasound enables us to see with sound, and it's a unique ability in the animal world. If you look at some predatory animals like killer whales, dolphins, or bats, they can echolocate, sending sound waves and catching the reflections and making sense of it. And this is exactly what we do. So why ultrasound? The first and foremost thing is that ultrasound is a readily available tool. It's inexpensive. It's a non-ionizing radiation, so there is no radiation involved. The safety is absolutely established, and it has got immense dynamic capabilities. So we could do dynamic imaging with ultrasound, and it allows us to do guided percutaneous procedures, which is established in the radiology world anyway, and a lot of patient interaction. And that's the reason why I have incorporated ultrasound in my regular hand surgery practice. How does it work? Very simple basic technique that there's a piezoelectric crystals which create sound waves. You send the sound waves down, and then it reflects back from different tissues with their different density, texture, produces different kind of acoustic reflections. And there are terminology there, if you're interested, like impedance and acoustic interface. And then we get these reflections back in the computer and make some images out of them. In the ultrasound world, there is frequency range ranging from 1 megahertz to 50 megahertz. However, as the frequency goes up, higher the range, it has capability of creating better resolution pictures of superficial structures. So for ultrasound in hand surgery, I prefer to use a probe which has, or a machine which has 12 megahertz and above capabilities. And that's what we will see. So how do I incorporate ultrasound in my practice? I started off using ultrasound for ultrasound guided surgery in outpatient clinic. And I started with an handheld device, which was a portable Clarius device, with limited capabilities, but enough to do carpal tunnel and trigger finger injections. And then I have progressed to do ultrasound guided surgery, specifically carpal tunnel and trigger finger surgery. So injections, I began with carpal tunnel and then trigger finger, then progressed to do thumb CMC joint injections for thumb arthritis, finger MCPJ and PIPJ, dequerbins, lacertus, and wrist occult ganglions, specifically dorsal scapholunate area ganglions. And ultrasound gave me the precision to localize them. So what's the evidence for using ultrasound? Why not blind injections? Because everybody does them. Why not X-ray guided injections either? So evidence is out there. As you can see, some papers starting from 2017 and some recent papers as well. And all these evidence are indicating towards reduced hazard of retreatment, better efficacy, significant improvement in patient care, patient appreciation, and faster return to work as well. And these are all established. Now, ultrasound-guided surgery. So injections are one thing, but surgery is an intervention and a procedure with lots of risks involved. So why would you do that? Simple answer is that it's an established technique, and you'd be surprised to know within the continental Europe, it's been going on for the past 10 years. And the safety is established. So the biggest thing is that ultrasound-guided surgery can be done in a clinic setting without an operation theater, which is brilliant for some simple procedures. You can bring them outside theater, reduce your cost, make it more green and lean. So here is a video of doing an ultrasound-guided trigger finger surgery, and this is how I do it as well. You need to use a hockey stick probe and then localize the A1 pulley. Start with your local anesthetic injection, which you can use with adrenaline as well, but I wouldn't do it because I want to see the pulsating arteries in the neurovascular bundle to localize my device carefully. The device you're seeing here is the Spirecut device, and I've got the device with me. If you're interested, you can come and have a look later on. And then the device has got a specific cutting technique which makes it safe around the important structures. And the technique is such that you introduce it, you then pull back, and then the cutting area, the surface, is very tiny, and it's on the upper edge of the device. This is the ultrasound-guided surgery for carpal tunnel, where I use a safe zone between the ulnar neurovascular bundle and the median nerve, and it goes in plane approach with the ultrasound guidance. A probe goes in, which creates a space. And the best thing about ultrasound-guided carpal tunnel surgery, according to the literature, is that you do not release the palmar aponeurosis. You just release the flexor retinaculum. And thereby, some suggest that it prevents pillar pain, which is a very common complication of carpal tunnel surgery. And the other thing is that the patients end up with just a simple, tiny hole in the hand without any incision. These are the devices which has got specific design features in them, and you can come and have a look later on. Benefits, green and lean. Cost for carpal tunnel within NHS, £1,800. If I do it in theatre, if I do it outside, £750. That's approximate estimation. Patient benefits, minimal pain, faster return to work, and you can use Wallant as well, and it's safe. Other uses, ganglion. I do use ultrasound for ganglion aspiration with needle. I use for diagnostic purpose, like scapholunate, occult injury, scapholunate instability, and also for flexor tendon, ruptured flexor tendon. I can use my scanner in the outpatient setting and confirm the diagnosis. I don't have to rely on a radiologist to tell me. And what do you need? High-frequency linear array probes and skills, lots of practice. Thank you. So, you want to be a great white shark or an orca? Orcas use ultrasound.
Dr. Sen, thank you very much. Also in time, interesting talk. So also ultrasound is very often used now in Switzerland for diagnostic tools, not only for operation. And I would be interested in what do you think about the sterile situation on the surface of the skin when you do operations? Do you use only something for disinfection, or you use gel?
So for operation, if you follow Donald Lalonde's work from Canada, he started bringing carpal tunnel trigger fingers into outpatient setting, outside theater. And he has proved time and time again with his work and with his publications that sterility is not a factor. You just need field sterility, which is basically cleaning the area. You don't even need the drapes that we use for in theater. And it's been proven that infection is not an issue at all. If you're doing metal work, that's different. But all the surgery a clean soft tissue surgery where field sterility is all we need.
And how many experience you should have with ultrasound if you start with operations with this tool?
I would say at least a couple of years of injection practice that will bring your skills up to the level, and then try surgery. I would never advise anyone to start with surgery because it takes a lot. Triangulation scale, looking at the gray scale images, which looks like 50 Shades of Grey and much less interesting, believe me, and then making sense of it, it takes a lot of practice and time.
Okay, any questions? Use the microphone, please.
Do you have a radiologist with you when you're doing, or you're doing it on your own?
I started doing it on my own, but I actually did myself a favor of going to a radiologist's clinic before while I was training for this. So I did cadaveric training, I did mentorship training with them, and then went to a radiologist and sat down with them to make sense of what's happening, understanding the machine, understanding different terminology, they call it knobology, how to understand the knobs on the machine and how to operate them. So yes, I would say if you have a friendly radiologist at your disposal, use them.
Yeah, one question. Interesting study, sir. We in endoscopic carpal tunnel release, we have been taught like we have to do previous ultrasound to get understanding of the palmar cutaneous branch. So during this ultrasound guided carpal tunnel release, have you encountered palmar cutaneous branch intraligamentous anytime? Any experience on that?
Do you mean the recurrent branch or the palmar?
Recurrent
branch.
branch.
My experience of doing ultrasound carpal tunnel is very limited, but the person who has got a huge amount of experience behind him is Fabian Mongundo. He's one of the inventors of these devices, and he has written on it. The publication speaks mostly about a thing called the Berrettini branch, which is a branch connection between ulnar nerve and median nerve in the palm. He has encountered subligamentous branch of recurrent median nerve very few times, and when he's encountered them, he actually managed to identify them. I don't think I have the skills to identify it yet, but having said that, if I see anything out of ordinary, I would stop and probably make myself to go and open it.
To open. Yep. Thank you.
Thank you, Dr. Sudhajit. We'll move on to the next speaker, Dr. Manjunath. He'll be speaking on diabetic hand infections, cutting-edge management strategies.
So very good morning to everyone. So from a place of sterility, we move on to great infection. So I'm presenting a topic on diabetic hand infections, and we'll define a few management strategies and reinforce the older ones. So diabetic foot infections are very well known, and the ulcers are documented, and there are also many screening and awareness programs. So this today's session will attempt to recognize the diabetic hand as a separate entity. So literature will throw up very contrasting studies. So one talks about outpatient management, whereas one from a major unit in South India talks about the factors influencing amputation, talks about hospital stay and the surgical procedures. So for managing a diabetic infection, we have to understand both the pathophysiology of diabetes as well as infection and the microorganisms involved. And of course, we'll discuss about wound debridement and knowing the anatomy, the spaces of the hand. So there are different types of infections. As this color plate from one of the articles shows that there can be a presentation from an acute paronychia up to a presentation with gangrene of the digits. So I found it in our plastic surgery textbook where Mohan and Jerry Joshua have described 4 types of infections. One is a subepidermal. Then the one is what we encounter, the cellulitis, which we define it as, which is it's better defined as a subcutaneous extrafacial dissecting infection. And there are injection site infections, and there is gangrene and necrosis at the time of first presentation. So, of course, we know the impact beyond infections. You all are well versed with the conditions like Dupuytren, or there is a peripheral neuropathy which complicates a trauma for a diabetic, and finger stiffness. So, and there are also devastating consequences, like this is a patient who had a run-over injury and he had a below elbow amputation, and he came to us complicated due to his diabetes, and he required debridement and skin grafting. We were still able to restore some elbow flexion for him. So staying updated is the crux of the situation. So this is a 10-year-old update from acute hand infections, which was published in American Society of Hand Surgery. So it states that the continued emergence of antibiotic-resistant bacteria, but the lesser development of the antibiotics to match it, they remain the main challenges in the care of these patients. And from where I come from in South India, the main problem is multi-resistant coliforms like E. coli and Klebsiella. These are already present in the patient's body, and they end up becoming multi-resistant after visits to multiple hospitals, which sadly is the scenario. So coming for antibiotic protocols, we have to define the protocols for the management of these cases, because most of these diabetic infections are polymicrobial. So the reason I included this slide is that once you see this appearance, like this is the classical flesh-eating appearance of Klebsiella, so you know that debridement is not going to help, and this patient is going to land up with amputation. So the one-size-fits-all approach doesn't work. The American Society has defined 11 types of hand infections. So here you can see the acute presentation of flexor synovitis, which is suppurative in nature. After 48 hours of antibiotics and leg elevation, you can localize the site, and later you are able to achieve a good range of motion. So while treating, the general conditions are, you have to consider admission to the department. And you can see Professor Kenavel has given us the gospel of the 4 cardinal signs of flexor tenosynovitis. And there is no substitute for a good clinical examination. And incision and drainage would be required, and regular dressings. And definitely your physician has a big role to play. The concomitant diabetes management is important, and the support from the hand therapist. So there are a lot of studies which are saying that the most common complication of a patient whose hand survives is stiffness of the fingers. IP joint stiffness is the most common. So we have to underline the importance of hand therapy and regular follow-up. Now an interesting entity which comes first, it was identified in Nigeria, is a tropical diabetic hand syndrome. And similar publications have come out of Libya and the African continent. And mainly it is defined by poorly controlled diabetes that is present, and there is a history of trivial trauma. And neuropathy and the microvascular complications are not very common associated with that. It's mainly that there is a delay in presentation, and the patient can present with gangrene and vascular insufficiency in your first consultation. So the Western counterpart, I couldn't find many studies because this is before the era of HbA1c. So in the 70s, the studies which come from the Western world, although they have an eerie similarity to these modern papers, still we don't have data of HbA1c, and most of the studies are under the general ambit of hand infections. So from India, we have a study from the eastern, northern, and the southern part of the country, and this is a large series of 51 patients which shows varying presentation, where they found that the random blood sugar and HbA1c levels were consistently elevated at the time of admission. So in this, 8 patients had previously undergone amputation. So that is the take-home message would be that the incidence of one amputation increases the risk of having another one if the sugar is not controlled. And those who had surgical intervention within 1 week, they did not require an amputation. So of course we have to credit Samuel Rehber, the Iranian who later migrated to the United States, and he described the connection of hemoglobin HbA1c along with diabetes, which has really revolutionized the management, and it has changed the way we look at these infections. So again, collecting a wound swab, that is need not be repeated. There is a technique where you have to collect it so that you avoid contamination, and then choose your antibiotic, talk to your microbiologist, and then choose when to escalate and when to de-escalate. And just in the closing slide, I will leave you with a quote from my boss, Dr. Raj Sabapathy, that there is no microorganism that is resistant to the surgeon's knife. So there is no substitute to an ideal debridement. And of course, remember the exceptions to the rule. Now, this is the patient of mucormycosis, where you can see the border of induration. So if you go and excise this, the mucor has an affinity for healthy tissue. So you will end up with a worsening. So the better option is to start amphotericin B or a broad spectrum antifungal, wait for 48 hours, and then proceed with the debridement. So these are the take-home messages, and good clinical examination has no substitute. Hospital admission whenever you are doubtful, antibiotics as per your culture, and we have recognized tropical diabetic hand syndrome. You have to anticipate vascular insufficiency in the future, decide early for amputation, and believe in teamwork, and of course monitor the HbA1c levels long term. So these are my references. Thank you very much.
Thank you for that talk. Do we have any diabetic questions? Yes?
So, after this debridement in diabetic hands, we get varied presentations when they come back. There can be osteomyelitis of the bone or the ligament which are there, they are already destroyed. How do you manage the reconstruction part later on?
Yeah, so in that case, the main the decision to make is whether you feel that the digit will survive. So like if there is an infection in the collateral ligament surrounding a joint and you don't expect it to recover, so even though you'll have a living finger, you'll have a stiff finger. Yeah. In that case, I believe that you do a complete digital amputation. Like in diabetic foot, they disarticulate the toe from the MTP joint. So here you can go ahead through the metacarpal head and this thing. We have to counsel the patient, but first.
I mean, that is the dilemma because they see a living finger and they are not ready for the amputation. Yes. So it becomes difficult.
Because any attempts at reconstruction will increase their cost and increase the number of visits. Yes. So that is the dilemma which you have to.
And second question, sir, during your daily dressings, do you give regular wash into the flexor tunnels or you put something?
Yeah,
like
there are two controversies regarding this. So one is using hydrogen peroxide on living muscle is again questionable. So what I do is I take betadine and dilute it with a few drops of hydrogen peroxide. Whereas directly if you spray hydrogen peroxide on an amputation stump, you can see the color change the next day. So you should avoid that. So that's what I feel.
Thank you, sir.
I have just another short question. So usually in Switzerland, if we have an infection, then we ask the internal specialist for infectious disease which antibiotics we should use. What's in your country?
Yeah, so here first we collect a wound swab. Then it goes to the lab. It gets inoculated, one of it. That after 48 hours, we talk to the microbiologist. In that time, the sensitivity pattern comes. So most of these hospitals here are using this Kirby-Bauer disc diffusion technique for the sensitivity. That's the basic one. There is also a PCR-based technique, but that is not commonly available and cost will increase. So based on the initial pattern, we start the antibiotic. So otherwise, we use a broad spectrum like piperacillin, tazobactam for a diabetic with uncontrolled sugar. It's a reasonable first antibiotic.
Thank you. I suppose no time for the question, but something to think about is the duration of intravenous antibiotics and the time to transition onto oral antibiotics for discharge, which is also very topical and interesting. So our next speaker on anatomical principles of safe wrist and hand surgery, Dr. Venkatesh Babu.
I thank you, the organizers, for inviting the lecture. And at the end of this talk, I think I would explain about the antibiotic. I want to touch a point with this. So the anatomical principles in preventing complications, which I feel these three things is important today. A lot of iatrogenic complications now. I think in the morning we heard about Sudhir Warrior telling that, cutting the radial artery and accepting in front of everybody. I think it's happening now, and then criminal liability and monetary liability and disciplinary action is in front of you. I think the anatomical knowledge and the precise surgical skills would save from all this stuff. So this talk will cover that. A safe surgeon is actually who has a very good anatomical knowledge and there are precise surgical skills. So which is going to make the surgeon and the patient, of course, to be very happy and in saving from all the litigations. So the entire talk will be based on my book, which I written 2 years back, and then the AO reference and the WHO. So these are the three things which is going to cover my talk. So the scheme of the talk will be about this is the scheme and the safe antibiotic usage at the end. So the distal radius fracture, whether you do it dorsally or volarly, you get a lot of tendon irritation even today. So how to prevent that? You must have a very good knowledge, and then the precise surgical skill. Again, I want to stress. And to avoid that vascular and neurovascular injury, you have to be very much knowledgeable. So how to avoid that? So two things we need to understand: that the sequelae of the entire the procedure, you have to be well versed, and then before knowing without knowing the anatomy, I don't think you should ever touch that. So keep refreshing it before going to the theater, and then always you practice that. And the hand and wrist surgery incision, even though it's small, it requires very much precise incisions, where necessarily border a lot of the nerves and the arteries, where you need to put the retractor in a certain angle and certain pressure, so you need to avoid the complications. So thanks to AO surgery and the safe volar approach will be the wrist approach, where you have to go in between the flexocarpi radialis and the radial artery. You have to go in between so that you can avoid the complications. So the entire the talk will be about a single or 2 points about each slide only, not in detail. And yeah, this is the very clear diagram which showing the radial artery and the flexocarpi radialis. We need to go in between to avoid all the complications. And the dorsal approach, there are about 6 compartments. In between the compartment you go, it applies to the wrist arthroscopy and your wrist approach as well. The dorsal approach, I'll just show one, and where you need to scoop off the external pollicis longus and then other tendons on one direction, so that you can avoid the complications. So this is for the dorsal approach. And the scaphoid, the volar approaches, you have to understand the 2 important structures, the median nerve and the vessels. So you have to go very much precisely in between to avoid the complications. So and the radial artery in the very small branch will bleed like hell, and then if you don't really address that. So, and the dorsolateral approach, of course, there is no vessel there. However, the nerve is there. So you have to be very much understanding that. If you cut that, of course, you're going to have a patient complaining about the sensation loss, where you're going to come and meet you often. And we have to understand that the ligament and everything, it be very much how much ever thin is needed. Don't cut just like that. Use the exact equipment and instrument, respect the tissues, and then go accordingly. And the external fixation of the distal radius fractures is the 2 points are important, and how going to avoid the extensor carpi radialis and the digitorum communis and the abductor pollicis longus. You have to avoid that one and then go past the pin. So 3 complications. One is the extensor tendon injury, and then superficial branchial radial nerve, and the metacarpal fracture. These are the 3 things you expect from the external fixation. So you have to have a larger incision instead of micro incision. You have to be very much needed incision to avoid the injuries. Then blunt dissection is of course is needed, and the pre-drilling of the incision, the pins. So this is what the safe for the metacarpal, where actually the head descends to the shaft, that is the area, and the shaft disappears at the base, that is the area. And the distal pin, as I said, it has been inserted proximal to the transition, and the more proximal is the transition to the shaft. So you have to hold in the both quarters. The eccentric should be avoided because it will cause fracture. And you flux the metacarpophalangeal joint for 90 degrees, where the extensor tendons will move away, so that you can place the pin safely. And the angle also is very important for this type of pin incision. And the landmark for the radial shaft, as I told you, to avoid the muscles and everything, I have to go, this is a cross section, where exactly you can go with an angle where you can avoid all the muscle injury. You have to be well versed with this knowledge. And the phalanx fracture, we have a safe corridor for 3 phalanges. So it's a triangle area for the proximal phalanx, where the safe zone on either side. And for the middle phalanx, again, the central slip has to be addressed. And the terminal phalanx, the FDP and the extensor tendon, where the incision. Other areas are very safe, where you can insert your K-wire. So this is the way you have to go for the proximal phalanx. And the middle phalanx, as I told you, the dorsomedial and dorsolaterally to address the central slip. So this is the green area which shows the safe zone where you have to go and then do the surgery. So, doing the surgery is very important, but doing well without any complications is very important. And this is a reference, and the wrist arthroscopy I just touched. And I just want to tell more about the antibiotic. Of course, this is the incisions for safe incisions, where we need to learn this. And my colleague was telling about my diabetic infection. The incisions are very important. So the safe antibiotic, you say I just want to use the 34 seconds, because the Indian government is being warned by the WHO that 52% of the antibiotic doesn't work in India, and a lot of over-the-counter antibiotic is being sold here. I think the one, we have about 30 plus states, and the one state in Kerala is 4 days back, they have implemented the antibiotic policy where the over-the-counter antibiotics is stopped. Now you can't buy any antibiotic in over the counter in one particular state at least. You know, it's a way forward. And we do appreciate that there is about only 100, I'll just take 10 seconds with the permission of the chair. Access, watch and reserve. These are the aware concept of the WHO, where only 85 drugs are allowed. You know, for the common cold, there is no antibiotic is needed. But I was, have interested to know about my colleague who said about piperacillin is the order of the day. I don't think it's allowed. It's a reserve drug. You should not use that. Being a center like yourself, you must form a stewardship committee where you are a pharmacologist, and then you have to involve the specialists. And then we do have in our place very small center. We do have that. And I published in my book also in that. So the WHO has published a book on antibiotic. I think you should follow that. So that is me, and thank you very much for the time. Thank you.
Dr. Babu, thank you very much for this interesting talk. Any questions from the floor? So we can listen to your book, and I think that we can ask every question if you want. So thank you very much. Because of time, we went further, and we ask Dr. Cleland from Australia to give us an introduction and talk about patient-related question outcome measurements, the PROMs.
So thank you for having me. Of course, in Australia, we can't keep up with the surgical skills of our Indian friends and colleagues, so I'm not going to talk about anything surgical at all and talk about some outcome assessments. There's no pertinent declarations. So this quote I actually stole from one of Ryan Calfee's talks, and I think it highlights something important, that the challenge for us surgeons can sometimes be our mistaken beliefs, things that we know for sure that aren't actually true. And the role of patient-reported outcome measures is trying to address that and inform us about appropriate patient outcomes. So why are we using patient-reported outcome measures? Traditionally, all we had to really go on were objective measures for comparisons, be that range of motion, be that grip strength. But unfortunately, as we've talked about a few times at this meeting, whether that's relevant at all to the patient in terms of their desired outcome is really not very clear. And in actual fact, our total active motion numbers that we care quite a lot about may be completely irrelevant to the patient in terms of what they were hoping to achieve from their medical intervention. So patient-reported outcome measures sort of began as a research tool to try and get a bit more feedback from the patients about what was important to them. And progressively over the last 10 years, there's been a real shift into trying to start incorporating that into our standard clinical practice. So I suppose part of the reason for this is that despite thinking we're excellent at assessing our patients' outcomes, the evidence says that we're really not very good at all in assessing our patients' outcomes. We assume higher levels of upper limb function than the patients report themselves. We believe there's lower levels of pain interference compared to when we actually ask the patients how they're functioning. And this can be up to 10 points of difference depending on which scale you're using. So we haven't really looked at how they're going. We've presumed things that are probably not true at all, and hence there's been a real sort of flush of available PROMs. And that's become a bit daunting for surgeons because there's so many PROMs available. So which PROM are we like? Which antibiotic are we going to get off the shelf? Which PROM are we going to start using to assess our patients' outcomes? So thankfully, there was a big working group, the ICHOM group, led by Stephen Hovius, and they had a Delphi process so they could all eventually agree, and they came up with 5 different measurement tracks that help guide how we should be incorporating PROMs into our clinical practice. The problem with that is that this is the list of PROMs that were recommended in the ICHOM guidelines. And this is the second page, and this is the third page. So to give you an example of their recommendation, for this track there was a regular and an extended track for each of their 5. This is the thumb, finger, wrist tract, baseline 3 months, 6 months, and down the bottom you can see the rough recommendation on the time taken to complete those PROMs, combinations of patient-reported measures as well as some clinical reported measures. And sure, we all agree that nerve surgery is complicated, so with the extended nerve track you can see that you're asking patients, you're asking patients to spend at least 45 minutes filling out your surveys. And I don't know if the Indians are far more compliant than the Australians, but I don't think that's actually very practical. So of course, last year that was looked at. They just sent an automated email process in Salt Lake City 1 year after a surgical intervention, just linked to a quick dash. There was a patient-specific link to a REDCap database, and they had a response rate of 27%. So that's not fantastic. How should we be using PROMs in clinical practice? Well, again, you don't need to worry. They got together a group of experts from North America, and they suggested 12 different process guidelines to this group to see if we can get a consensus. And unsurprisingly, they didn't agree on any of those guidelines whatsoever, so we had nothing to come away from, aside from the feeling that a patient's score on a validated PROM should be verbally communicated to the patient at each visit. And I think that's a really valuable takeaway, because if you're asking your patients to spend their valuable time completing all of these surveys that then just gets handed in or goes into a computer database and they've never had any feedback on what they've told you, they're not feeling valued at all in that interaction. So if you can sit with them and say, oh, I can see your dash score was this, and last time I saw you it was this, so I can see you're going really well, and these different domains are areas we might still need to work on. That's of course a bit of feedback for them that what they're doing for you is valuable. Now, just because we had this focus on patient-reported outcomes, because the patients reported it, that isn't actually a direct link with it being valued by them. And our PROMs are still quite blunt tools, and there's a little bit of a shift in this space into something called a patient-centred outcome measure. And an example of that is something called a patient-specific functional scale. And what that allows is, in a more open sense, for the patient to identify specific goals. And that might be returning to yoga, that might be going hiking, that might be being able to wash the clothes. And that's identified, and then progressively over time, through scales like this, you're assessing their ability to do the function that you know is very important to them. 77% of patients found the patient-specific form more helpful than the quick dash for lots of different reasons. A few ways that we can improve our response rates: you've really got to make it personal to them. A little video in the age of IT, a little video introduction that's attached to your link saying, thank you for filling out this form. I really appreciate the time that you're spending doing this, and this is going to be helpful for me helping other patients in the future. Reminders with the requests, electronic collections so there's no human double handling, and most importantly, discuss the results with the patient so that they've got buy-in into the interaction. I don't know, it's just a little plug for a new one that's quite patient-centred called the Hand Q. Thank you very much.
Dr. Cleland, thank you very much. Very interesting talk. And I think it's very important that we know that there are PROMs. But during your practice, daily practice, which PROMs do you use?
So we've started using the Hand Q because that was based on 6 different countries, including Australia, so it's quite relevant to the Australian population, may not be transferable to the Indian population, and we still use the Quick Dash for some data collection as well, although we acknowledge it's a blunt tool that might not be super helpful in many different instances.
Did you also consider the brief Michigan hand questionnaire, for example? It's quite short.
We did, yeah, so that's certainly a lot better than the full Michigan hand questionnaire, but again, we found that there's lots of elements to many of these that just weren't particularly pertinent across the breadth. There's no one-size-fits-all that really works, and I don't want you to all have 40 different proms. You know, you've got your carpal tunnel prom, you've got your de Quervain's prom, you've got your Dupuytren's prom, but the patient-specific ones are quite useful because they can be a bit transferable, and each individual patient identifies important goals to them.
Okay, questions?
Hi, it's an excellent one. I just missed your point. Did you give the mobile phone app or something like that you developed?
Yeah,
or
so
just a cold email, because I was worried that 27% only responded.
Yeah, so that study was just a single email link sent to the patients. We use a text message system through REDCap.
No, I think, may I suggest, why don't you use this Google form or like that, very simplified one where...
Yeah, so Google Forms are good. The REDCap we use because you can build in all of those forms that are just easy press buttons to respond that can all be done on the mobile phone, and it's all, as opposed to a Google form, it's all automatically linked into the data collection that we can use for whatever trials we're doing.
Yeah, I think with that, I think you'll get 100%.
Yeah.
With everybody, 2 mobiles maybe.
We never get 100%.
Sure. We'll have one more question and then we'll move to the next speaker.
Thank you.
Please, go ahead.
Great talk, Brett. Thank you so much. I know we've been talking about it. It's part comment, part question. The circumstances in which the patients fill the form in has an impact on the responses that you get. So depending on where they are, who they're in front of, what mood they're in, also has an effect on the scoring, I think.
That's right.
And it's such a... There are so many variables to it, it's just hard to...
It's never really been looked at, but I think it would be interesting, different formats of having an iPad or something in your clinic setting that they're filling out. I would be curious to see if there are differences, how they fill it out sitting in your waiting room versus how they fill it out sitting at home. It would be interesting to see.
Okay, thank you, Dr. Brett. We'll move to the next speaker, Dr. Adeline Clement. She'll be speaking on high-pressure injection injuries, advanced treatment approaches.
Oh, this is extremely tall. Let's bring us down. Good morning, everybody. Thank you very much for having me speak. This is a topic that's quite dear to my heart because I'm quite involved in this back in the UK. You've already heard my colleague, Mr. Sen, speak. We're from the same unit up in the north of Scotland. When I normally do this, I do this as part of a team at IFESH and BSSH meetings in the past with Professor Warren Hammett, who is a professor of orthopedic surgery in North Carolina, and a couple of my other colleagues. So some of the slides are from them. That's my acknowledgement. I have no disclaimers. I do advise for the health and safety aspect in the oil and gas industry sometimes, but there's nothing to do with this particularly. So high pressure injection injuries, this may not be a topic that's new to you because I'm sure most of you have seen this in your practice at some point in your career. Thankfully, it's becoming less of an occurrence in the UK because of education and prevention in industry. They're often innocuous, tiny little wounds akin to a cobra strike. So if a snake were to bite you or a cobra were to strike you, you'll have a tiny little penetrating wound, but the damage underneath is quite extensive. So you can see from this image alone, there's a tiny wee wound on the base of the index finger, but the position of the finger is almost in Cannavale's classic description, flexed, red, swollen, okay? This is a picture actually from an Indian publication in the BMJ, and it shows through a small injection injury of dye and paint base dye, the extensive damage underneath is quite significant. So it's underestimated because patients think it's a trivial injury. They don't come until much later on when they have significant symptoms. Employers think of it as a trivial injury because there's only a tiny wee hole, so how bad can it be? And then health professionals, particularly in your A&E department, if they're assessed by someone who's inexperienced or not seen this before, often send patients away with analgesia and some antibiotics and say, come back if it gets worse. So first documented back in 1925 from diesel fuel injection, often manual workers, male, non-dominant index finger, because you're using the pressure gun in your dominant hand, and then your index finger of the other hand gets in the way. Up to 1 in 600 hand trauma cases in the UK and worldwide, but this number thankfully is becoming less. You might see more of this in India. And about 6 per annum to tertiary hand centers, usually because of human error in the way they use the equipment and equipment malfunction. So some of the pictures show how you can get this into you. A thought to take away, in the UK, many people let their teenage children clean their drives with a high pressure washer. So just even if you learn nothing from this talk, think about when you let your children use the high pressure washer to clean your driveway. So the pathology of injury, 4 phases. The main thing is a chemical response and a huge cytokine inflammatory response. And then finally, you get a secondary infection or necrosis. The physical injury causes irritation, vascular insult, compression of the neurovascular bundles, and then necrosis. The pressures generated in these devices can go up to 12,000 psi, but to breach skin, all you really need is 100 psi. So if you hit yourself with a pressure washer, you're going to actually cause quite significant damage under the skin. Okay? The chemical properties of the injected agent is important. So air is better than water-based paint, better than vaccines, better than grease or spirit-based paints. The worse or more dense the substance, the higher the cytotoxic or chemical cascade it produces. Contamination, often if you're using water to clear a certain area and it's being pumped from an external source, you can have atypical bacteria, often polymicrobial. These instruments are stored, sometimes not in a great place. Commonly seen are gram-negative and staphylococcus infections, but also fungal and atypical bacteria such as mycobacterium. This is a true surgical emergency, so if we see one of these patients, we take them for urgent debridement. Initially, they get tetanus, elevation, non-steroidals, antibiotic cover until they get to theatre. Debride, release the compartments, dilution, irrigation. The solution to pollution is dilution, so lots and lots of wash and trying to get rid of as much of the material in the soft tissues and under the skin as possible. And then post-operatively, you need a dedicated hand therapy service because these patients often are left with quite big wounds, multiple visits to theatre, and quite a lot of scarring, so you need your hand therapist to be invested with an invested patient. So the next 8 slides come from Professor Hammert. Usually small entry wound, proximal tracking through tissue planes, intense chemical reaction. Again, very small, tiny little hole from a paint gun, but underneath you can see the whiteness of the paint that's under the tissue, and you can see the neurovascular bundle where it's coating around, and the distal end of the neurovascular bundle is already looking ischemic. It's kind of white and lost its color. And these patients were all taken for immediate incision and drainage. So another similar picture on X-ray, you can see either foreign body or a little bit of the paint material, and just a tiny wee hole in the tip of the finger. Now if you look at the picture on the left, the finger's already discolored and the vascular insult's happening as you look at it in theatre. And again, once you've debrided it, you can see how the tissues have all changed color as well, and the extent of the damage under the surface of the skin. So lots and lots of debridement. This gentleman went back to theatre several times. Eventually, you can see the skin becoming ischemic, and the fingertip has not been viable. He's quite a stoical chap, so he was not bothered so much about the aesthetics. With the dedicated hand therapy team, he got pretty good range of movement back, and his finger is the way, as you see it now, functional. This is an X-ray just to show the outline of the paint just under the surface of the skin. You can see it elevating almost just over the layer of the flexor tendon sheath. This image is not that clear, but you can see a tiny wee entry point. In fact, this image is not from Prof. Hammert, it's from my colleague, Mr. Sen, who recently washed this gentleman's finger out, again from paint insertion into the tip of the finger. So key is education, patient education, protective equipment, safety equipment, employers' education, health professional education, so you know what you're assessing for. And if you educate in time, you probably prevent a lot of these injuries. Just a quick touch on vaccine, because we see this quite commonly in our area. We're very agricultural and very rural. The vaccine also is a high pressure injury in salmon fishing, salmon inoculation, cows, sheep, pigs. It is a fixed volume device though, so unlike your pressure washer, which gives out a large volume, it gives only a small volume. There's still quite a bit of damage underneath, but not as bad as the high pressured devices. So these are just examples of why you get salmon fishing, which you may not see here. It's common for us in the north of Scotland. But people get it because they don't have the right equipment, the right techniques. The oil-based item in the vaccine can cause a bit of tissue damage underneath and a chemical reaction. But it's really important that you tell your patients, particularly, of a delayed anaphylaxis or hypersensitivity reaction. So if you are used to vaccinating animals and you inject yourself a second or third time, you may well get anaphylaxis to the vaccine. That's it. Thank you very much.
Thank you for that excellent talk. It certainly is a widespread problem in Australia as well, and devastating injuries masked behind tiny little holes in the skin. Any questions on high pressure injections? Yes?
Very nice presentation. So I just wanted to know what is the average delay that happens from a rural area to reach you for the high?
So that's a great question, because we have a catchment area that's over 200 miles. So our hospital can be sometimes 200 miles away from patients. And that's part of the problem. So for the salmon vaccinations, if they don't know about it and they leave it a day, they often come back with a flexor sheath infection before they present. It's very unusual now because the industry in the UK has so much in their induction on health and safety that people usually know, employers know if they've had that sort of injury to get them quickly. So if they're in the islands or on oil rigs, they get flown in. So there's a delay time of being transferred in of that time. Usually we try to get them to theatre as quick as possible. It isn't always possible in a remote hospital because of access to theatre, but it is done usually within the 12 hours of an inoculation or injury.
Thank you.
Yes.
As far as antibiotics, how long do you give antibiotics?
So it depends on what vaccine it is. So if there is a vaccine-related, what type of injury it is. If it's vaccine-related injury, then we're looking at polymicrobial. So again, as my colleagues have presented before, we usually interact with our microbiology team, and they have set protocols for what type of injury it is. If it was fish-related, marine-related, if you're thinking there may be Mycobacterium TB or farm-related, then there's set antibiotic guidelines for it. So we use our hospital guidelines essentially. The more contaminated you think the wound is, the longer you'll be on antibiotics for. It also depends on how often you're taking them to theatre, how long the wounds are open for, and how much procedure you're having to do. For the diesel gun injections, we usually have a standard protocol of 5 to 7 days, more as a prophylactic. But for the ones that are contaminated, usually farmyard or agriculture, they're on it for a little bit longer.
Because recently I had a case, similar came delayed presentation, and it was very swollen, something like a macrodactyly picture. And all thing came negative. All cultures, even atypical, everything is negative, but it's not settling down.
And that may be that may be the inflammatory response though, because they get a large cytotoxic granulomatous response.
Nothing found inside. Nerves thickened almost 4 times the digital nerves, but still not settling. So I don't know what to do.
I think one of this will probably be a combined approach of discussing with your micro team, and probably not even having the antibiotics on board, but just letting time see even being off antibiotics to see how well it does after your surgical procedure, to let the inflammatory response settle.
Yeah, one last question.
When you explore and you find that there is ischemia, that ischemia, or it is due to the temporary spasm, or there is thrombus or anything like that?
Yeah, so like with most patients, they don't like the thought of an amputation immediately. So you do a thorough debridement, the first procedure. You warn them before you go to theatre that this is a bad injury, and the worst prognosis is you lose your digit. But you don't have to do a primary amputation. You can do a thorough debridement, wash out, cover it up, just as Prof. Hamid did with his one patient, and see how that manifests over time. If it's clear that it's going to become ischemic, then you may have to bite the bullet and amputate.
No, can we put a vein graft and revascularize that part at the same sitting? That is what I'm trying to ask.
But if you're worried about things like infection, and also you may have to go several times to clear the stuff. So if ever you've tried to clear grease or paint substance, it's not that easy. So you can't dilute it. You have to scrape it away quite a lot. So you may find that you won't want to do a graft immediately and just give your bed a bit of time to settle, especially if there's a large inflammatory response.
Okay, thank you.
Thank you very much.
Thank you.
Our final presenter for the session, Dr. Srikanth, on management of hand in EB.
Good afternoon, everybody, chairpersons and the audience. I must say I'm a little surprised to see the audience, so many being here today to listen to this. So if it seems a bit rushed, I'm sorry, because we have a very short time. So here we go. Epidermolysis bullosa, it's a rare congenital condition. It's basically manifested with fragile skin, and this fragile skin heals with secondary intention, leading to contractures. The contractures happens anywhere where there's epithelium, mostly common in the hands, the oral commissure because they eat, the esophagus, so that gets a small shearing force which causes it to get damaged and then heal with strictures, and then they get strictures in the esophagus. So there are 4 major types: EB simplex, junctional EB, dystrophic, Kindler EB. This the pediatric dermatologist will work it up very well for you before he sends the child to you. So this is, just to recapitulate, this is the structure of the epidermis. In patients with epidermolysis bullosa, the blister forms between the epidermis and the dermis whenever there is a very minor shearing force. This is basically due to the malformation of collagen. It is a genetic condition and this is not curable. So what happens when there is a blister? First, there is a shearing force, then there is a blister. This blister heals with secondary intention, and when this secondary intention happens across joints, either like the fingers, the hand, the elbow, the knees, or the esophagus, it causes a contracture. This is the typical presentation of the child. You have contractures of the hand, feet, elbows, oral commissures. They have poor nutrition, and generally they are small for age. And from a surgeon's perspective, there is a paucity of donor site, and as all hand surgeons, we know that, how do you do physiotherapy in this? Because when you do physiotherapy, you're causing some force which is going to damage the skin again. So as a plastic surgeon, where do we come in? We come in as to prevent blisters, we come in for wound care, to prevent contractures, and for the treatment of contractures. So what we have is a dedicated protocol. We teach the family how to treat the wounds, how to prevent further damage from the blisters. This is an example of how we teach the patients to prevent further contractures. Lubricate the hand well, place gauze pieces in between the fingers, secure it with a good bandage, and this has to be done about twice a day. And if the parents are diligent, they can avoid hand contractures, as we can see in this child who is about 11 years old, and here there is no contractures. However, when these things don't work or the patients are not, family is not well educated, if they don't follow these things, they end up with a contracture which almost results in a completely cocooned hand. So the surgery where we come in is for release of these contractures, whether it's the hand, the knee, the foot. Sometimes they have microstomia. And almost all of these patients, actually I must say all of these patients in our series have had esophageal strictures, and therefore they will always need a esophageal dilatation, and in rare cases we even need a PEG insertion. So how do we treat these people? Because you cannot handle them, they're fragile. There are a lot of challenges, especially the anesthetic problems. There are challenges in getting the IV line, there are challenges in fixing the tube. What we do is to make sure that no sticky tape is used across the skin, and whenever you have to intubate the child, make sure that you secure it with a well lubricated bandage rather than put sticky tapes across the face, because when you peel it off, you are definitely going to cause an injury there, and that is going to not heal over for a period of months. Then the other thing, as I mentioned, that we always have, you will always need to do a esophageal dilatation. Make sure that you have covered the oral cavity and the face well, so that at the end of your surgical procedure, when the gastroenterologist comes in for a dilatation, he does not cause any further trauma, because they do not have any experience in managing wounds, and we know how difficult it is to treat the wounds of these patients with EB. Coming to the surgical challenges, we have shortage of skin graft. Normally we take it from the thigh or the leg, but in these patients they may have ulcers there, they may have wounds there, and these sites may not be available. So we take it from the scalp. There is a technique called blister grafting, where you just rub the skin, lift the epidermis off and use it like a stamp. We mesh it widely so that you can cover large areas, and of course the stamp graft, which is a technique which we borrow from treating burns patients. So This is an example of how we harvest the skin graft from the scalp. It is a very good, useful donor site, and it can be harvested again and again. This is the photograph of a child at the first dressing, which shows that the hair growth is good. And on the other photograph, you can see that the hair growth is fully normal. One of the hands I've operated, and the child has come in for the surgery of the second hand. This is the typical presentation of a hand contracture. They're almost fully cocooned. Till they reach this stage, they feel that they don't require surgery, and it is a challenge how to treat these children. The contracture release is fairly straightforward. You get a good plane to release the contracture, and even in a cocoon hand, when you release the hand fully, usually there is no neurovascular compromise, and you can release the finger fully. I prefer to keep position with K-wires because it's very difficult to splint these people for a long time. I would aim at getting a intraosseous K-wire, but sometimes it doesn't go in. I wouldn't try to fit it again and again because the more you handle the hand, you're going to lose the skin on the dorsum of the hand. The skin graft is secured with 4-0 monocryl, and the first couple of dressings are always done under anesthesia. This has to be slow, and then that you find that you can get a good result. There are a few examples of the patients that we have treated over time. You may have to combine other procedures with these because these children cannot keep coming again and again to OT. So you can release the knee contractures. You'll have to do an esophageal dilatation, probably add a commissuroplasty, and if necessary, a peg insertion if their nutrition is very, very poor. So the key points to remember: keep the patient comfortable, allow the parents to handle the child as much as possible because they know what and how to handle the child without causing any further injuries. And all the people involved, right from your staff to the preoperative nurses to the OT technician, should be sensitized as to how to handle these children. Only then can you get away without damaging the skin of these children. It requires a lot of teamwork. And this is my observation over the past few patients that I've treated. A written SOP always helps. Give it to everybody who's involved. Patients are happy even though the results are suboptimal. With touchscreen devices, I find that a lot of the children don't want their hand to be treated, but they would rather need their knees to be released because they would like to walk on their own. Many of them will require financial support, whether you have a social worker, sometimes crowdfunding, sometimes this online organization would help to raise funds. All of this I have used to raise funds for these children. And thank you. So, any questions?
Dr. Shrikant, thank you very much. A very interesting talk. Usually epidermis bullosa we don't see in Europe very often, so I think it's more typical for India. Are you a specialized center for this disease, or do you?
I think I'm not the one who specializes. It's my pediatric dermatologists who are specialized in treating epidermolysis bullosa. So we get referrals from across the country. I am involved only in their treatment of hand, and so over a period of time, we managed to build our practice to this level. So what we do is we have an EB clinic once in a while where the pediatric dermatologist sees, the pediatric gastroenterologist, then we have a dentist, myself, and the anesthetist. All of us sit together, evaluate the patient, decide if we need to do surgery, how many surgeries, what is the sequence of surgeries, and we've been doing this for the past 12 years or so.
Any questions?
That was a very interesting talk, sir. How does the condition affect the rehabilitation in such cases?
It's almost impossible to give them physiotherapy. And children being children, you just tell them to play around. I find that they get a reasonably useful function. Physiotherapists, how much ever we try to train them, I don't think they're able to give a good therapy without causing any shearing force, and that the family and the children are very unhappy to go back to them again.
Thank you, sir.
So thank you very much. Last question.
Sir, any dressing protocol you want to tell?
Yes,
anything?
I do have a dressing protocol. What we do is for all these patients in our EB clinic, we have a video of how to do the dressing, if it's the periphery, or if it's for the hand, or if it's for the toes. We share it to them today with, with WhatsApp and social media, and they see it. I put it up on my online YouTube videos also, so they can just have a look or refresh their memory. So whenever they're at home, if somebody needs to see how to do it, they see it and do it on their own.
So thank you very much,
Thank you.
Dr. Shrikant, and thanks to all the speakers. Then we close the session because we are on time now. Starts the Oratio in the Galaxy Room with the Kienberg's disease. Thank you very much to the speakers, also to the chairs, and we'll see you later.